Hello, everybody. I'm Dr. Ahmed Al-Alfi. I am oncology medical oncology consultant at Oncology Center of Mansoura University. Today, I will present an interesting case I saw at my clinic here in KSA. This is 52 years old lady with bone mets, only and
Uh,
CNS
One
progression.
second, we cannot see your screen yet.
Okay.
You paused it. Yeah, now we can. Yeah, go ahead.
Okay. So this patient, 52 years old woman, initially diagnosed 2019 as stage 2A, T2N0M0, hormone receptor positive, HER2 negative, AKI was low at 12%. Recurrence score was done post mastectomy, post breast conservative surgery, and was found to be low at 15. So no adjuvant chemo was given, and we started her on adjuvant anastrozole. She continued it for 4 years before developing her first recurrence at 2023. She presented to us with mild back pain and fatigue. Imaging show bone-only metastasis at T8, L2 sacrum, right iliac bone. Biopsy formal bone show hormone receptor positive, HER2 negative, AKI still low at percent. ctDNA profile was done using Garden 360 test, which show BIK3CA mutation, and the ASR was wild type. We initiated here on ribociclib, letrozole, according to Menezatu trial, and she maintained a partial response for 22 months. Second progression was noted in July 2025 with new symptom of gait imbalance, dizziness. The MRI brain shows three enhancing brain metastasis, systemic imaging stable bone lesion, ctDNA was repeated, and the SR now was found to be mutated at hotspot mutation Y537S. BIK3CM mutation is still present as expected. Her performance status is 1, excellent. CSF cytology was negative, although it wasn't necessary. So this molecular timeline, initially LSR was wild type, but later she developed the hotspot mutation. BIK3CA was mutant at the initial and at the progression. No other mutation was detected. Regarding the BIK3CA and the LSR mutation and the hormone receptor positive breast cancer, the BIK3CA, according to the literature, is found in 40% at the diagnosis and at the progression. It is a static biomarker, not dynamic like the SR1 mutation, which also found at around 40%, but only after progression on AI. So the ASR mutation need serial monitoring, as we will discuss later. Combined mutation of the BIK3CA and the SR was found at 10 to 20%, although the literature was unclear about this prognostic value. So regarding all the question, ctDNA versus tissue-based testing for both BIK3CA and the SR and the other mutation. Now the standard we start with the ctDNA. For most common mutation BIK3CA, LSR, LAKT1 mutation will be TAN, all detected with the ctDNA companion diagnostic test. Even the SR mutation has no tissue companion diagnostic approved by the FDA. So back to our case, CNS only progression after 22 months of systemic control, co-mutation of the SR1 and the BIK3CA. Our management goal, CNS control and prolonged systemic disease suppression. We may have prevented this progression by adapting Serena 6 trial protocol through serial monitoring of the SR and the early initiation of Alpelisib before radiological progression. But Alpelisib not yet FDA approved. is presented at last ASCO with excellent progression-free survival from 9 months to 16 months with hazard ratio of 0.44. So for this patient, we have a lot of therapeutic options. All are FDA approved. Elacestrant, according to the Emerald trial, for SR1 mutant profile patient with HR hazard ratio of 0.55. Cabivacirtinib and fulvestrant, according to الكابيتيلو 291, for ACT B10 BIK3CA altered tumors with progression-free survival hazard ratio 0.50. And Alpelisib fulvestrant, according to SOLAR 1 trial, with good progression-free survival of 6 months. We have also two antibody drug conjugate, both targeting TROP2 biomarker, sacituzumab govitecan and datopotamab deruxtecan, both are FDA approved. And now we have a new player, Inavolisib with البالبو, sorry about that, Inavolisib with البالبوcyclib and the fulvestrant, triple therapy, which recently show overall survival benefit in this endocrine resistant population. And it is actually the first target treatment in the BIK3CA mutant tumor to show overall survival benefit. And it is also the safest, comparing to Alpelisib and the Cabivacirtinib. Discontinuation rate only 60% compared to 25% in Alpelisib and 10% in Cabivacirtinib. We have also two, as I mentioned, two approval antibody drug conjugate against TROP2 with payload with similar mechanism of action, topoisomerase 1 inhibitor, but different drug. In Trodelvy or sacituzumab govitecan, we have the SN38, and the datopotamab, we have deruxtecan payload. So explaining different toxicity. And the sacituzumab, we have neutropenia, diarrhea, fatigue, alopecia. And with the datopotamab, we have stomatitis, interstitial lung disease risk, and ocular event and fatigue. Only Trodelvy show overall survival benefit. Datopotamab failed to show that. But with this all options, all of them have limited efficacy in CNS metastasis. So we can consider Abemaciclib in this scenario, given its potent CNS activity. The patient already received CDK4/6 inhibitor, Ribociclib, but we can give her Abemaciclib upon progression according to the post-monarch trial. So after discussion in MDT, we managed her with local treatment, SRS, to the 3 brain metastasis, systemic therapy, which shows Cabivacirtinib with the fulvestrant to cover both the SR1 mutation and the BIK3CA mutation. Although the fulvestrant not direct inhibitor of the SR1 mutation, it's just indirect inhibitor, not unlike elacestrant as shown in Emerald trial. We opt for monitoring MRI brain and CT CAP every 3 months. Inavolisib not available now, but we can consider it off-label upon progression. So now I have finished my case. We have a lot of questions, but first I have to hear your thought about this case. Dr. Ahmed?
Yes, أنا معك. أولا طبعا I have to say that is exceptionally phenomenal job. You know, really incredible insight and very updated, you know, discussion. I mean, considering Serena 6 has been less than 2 months, honestly, and it's been presented early June. And And there's a lot of conversations back and forth about implementation of these techniques. But again, phenomenal job. Like, I really, really salute you. So that's one thing. The other thing is, we have to talk about, and this is a complicated case, but complicated in a good way, meaning that you actually do have options, as opposed to some of the complicated cases with no options to treat. As you mentioned at some slide at some point, there are multiple ways that you can approach this case. Now, what her first line was ribociclib and letrozole, correct?
Right.
Okay. But she progressed after finishing 5 years of adjuvant AI, or 4 years adjuvant AI, or she had been on the AI before
She was on AI.
she was on AI.
Yes.
Right. And then you very eloquently captured in PIK3CA is what we call truncal mutation. Right. So it happens at the start and continues, as opposed to ESR1, which is an emergent mutation. So it emerges after treatment. So you do a therapeutic pressure, and then you pick out ESR1s. And ESR1s tend to be about roughly 40% in the second line, as opposed to very rarely 2 to 3%, maybe 5% on the first line, like when you have a patient like that. She actually would have a little bit of a higher risk of getting ESR1 because she was on endocrine therapy and then she progressed. So one of the main reasons is, why did she progress on endocrine therapy? And a possibility is obviously having ESR1. But if she had a PIK3CA mutation in a truncal fashion to her disease, that creates endocrine therapy resistance, all right? So that's why, that can explain why the short-lived duration of endocrine therapy anyways. Type. Now let's talk about some of these questions, because I think that they answer some of the points. But before I continue, I think هل في any who's else on the call علشان like أنا شايف دكتور ابن خالد أبو العزة شايف like some minds are definitely smarter than me, فأنا عايز أعرف يعني who else that we can share the podium here about discussion and have it more of like a back and forth conversation.
We have Dr. Manar.
Dr. Manar, okay. Yeah,
the rest of the panelists didn't join, fortunately.
Yeah, it's okay. We keep doing on what we keep doing. I mean, honestly, that was a fantastic conversation. If we do one of those every month about different case, people will join. I think this is a really good discussion and a great refresher. طب let's talk. And I mean, we just share خلاص احنا good intimate group. Let's just have some fun with some of these questions. So أول حاجة, given relapse after 4 years of adjuvant AI, 22 months in letrozole ribo, does this qualify the primary or secondary endocrine resistance? I mean, she progressed while on endocrine therapy, right?
Right.
Okay.
After
So yeah,
after
go ahead.
4 years. After 4 years.
After 4 years of finishing endocrine therapy?
No. On.
Yeah. So that's primary. That's by definition. Now, what happens in the metastatic setting is different, the definition of endocrine refractories, and برضو, and to be frank, I'm not sure exactly of the exact ESMO definitions, because I work mostly with the ASCO definition.
I think it is the secondary endocrine resistance, since she was on the adjuvant setting and more than 2 years on AI. So I think it's secondary endocrine resistance.
This
It
is
is
the
endocrine
definition.
resistance. It is secondary because of progression after 2 years on an adjuvant.
Yeah.
So if they've been on the adjuvant setting for 2 or more years, that would be secondary resistance as opposed to primary.
And in
Yes.
metastatic setting, we use a cutoff of 6 months. 6 months.
Yes.
الانافوليسيب النيو بلاير and الانافو 120 trial
Yeah.
only for endocrine resistant, either primary or secondary. They excluded actually endocrine sensitive tumors.
Right. I think their definition was on endocrine or within 12 months after finishing endocrine therapy.
Yes, yes.
Yeah.
Endocrine-resistant tumor. Very difficult to
Right.
do. And even though they show overall survival benefit.
Yeah, it's the only big 3CA with the overall survival benefits. You're absolutely correct. Okay, I learned something new. I honestly don't think that primary versus secondary is used as like hatta, like what you just said is not actually what Alpelisib has been done for the clinical trials, because on the clinical trial, it's on endocrine therapy or progressed within 12 months after finishing endocrine therapy. So a little bit of a slightly subtle different definition to this, but that's good. Okay, so this is secondary endocrine resistance. Do the brain metastases alone constitute a visceral required to justify immediate chemotherapy?
This patient didn't receive any chemotherapy, either in an
Yeah.
adjuvant section or in metastatic section. So,
She's symptomatic with symptoms of
course.
increased intracranial tension or no?
just dizziness, just dizziness.
Okay, I think a
Dizziness,
visceral crisis means it has to be symptomatic one way or another. Like if there is liver mets, it has to be translated into elevated liver enzymes and serum belly, or present with abdominal pain. If there is long mets, you have to be symptomatic with dyspnea and shortness of breath, etc. So for me, I wouldn't consider it a crisis if she doesn't have significant symptoms. What do you think, Dr.?
What about increased intracranial pressure, seizures, coma, which qualify now for
The
chemotherapy? Would you give any chemotherapy for this patient in such status?
tough. I mean, I would agree with Dr. Manar. I don't think this is by definition visceral crisis. It's visceral crisis. There's a couple of things that I can say. First off, right, chemotherapy is not going to cross your blood-brain barrier. So, so I don't think it's going to affect your CNS disease. Okay. The second thing is, even when you talk about visceral crisis, you have the right choice data, the right choice, with scallium. So the right choice was comparing chemotherapy to ribociclib, right? With the right choice, I think so. And then these were all patients, right choice with acute
Yes, it was against ribociclib plus
right?
AI.
Yeah, right choice, like ribo AI versus chemotherapy. And guess what? People who had ribo and AI, visceral crisis, liver, there's some lung, and they actually did better than chemotherapy. The only benefit of chemo in this patient was that the time to response was shorter. Probably, I think 2 months versus 3 months time to response. So if you have a patient that is actively getting worse, liver disease, like 300s, 400s, actively getting worse, you're worried about the initial time to treatment response, you might want to do a little chemo. But in a patient like that, hatta if there are symptoms from brain disease and you have an increased, if you have an increased LP pressure, you might have a potential LMD. That's a whole different scenario, right? But just brain disease, little steroids, little RT, involved neurosurgery. There is a role for resection. Most of the time there isn't. I would just treat locally. But that's my thinking process for patients like that, because we don't see them also that often, anyways, in that setting, right? They're not as common, brain disease for the ER positive. So
10%. Rare.
yeah, and right, exactly. It gets even more complicated because they're not inherently chemotherapy sensitive. But I would not do immediate chemo in a patient with brain met, حتى لو عندي triple negative patient necessarily and with a new brain met, because even chemotherapy is not going to go into your blood-brain barrier.
So I want to ask a question. How many bone mets does the patient have? Are they extensive or localized? Can we consider this patient
Three.
oligometastatic in the bone?
Three less than, all are less than 3 centimeter.
So the bone mets are the bone mets. How many sites?
البون ميتس 3 sites also. Let's check. T8, L2, sacrum, right, iliac bone. 4
Then,
sites. But
so
upon second progression, it was stable.
yeah, did she receive radiotherapy on the bone metastasis?
Yes.
Okay. So we have like 4 sites on the brain and the three brain lesions. So can you consider this an oligometastatic disease or no?
I mean, they're
Uh,
less than 5.
yes, most guideline restrict to 5 per organ, but I'm not sure.
So 3 brain mets can be considered as one site and plus other 4 bone mets. So can we go for a stereotactic radiosurgery or something to the brain mets and also something local for the bone mets?
This is our last question. Regarding the oligo progression, CNS progression, can we adapt the non-small cell lung cancer with actionable mutation approach, continual osimertinib or alectinib, and target CNS progression locally with the SRS?
Yeah. No, I think this question is very challenging. And again, most of the time you don't know if the change of the systemic therapy will equal an improvement in the intracranial disease, because not a lot of the drugs that you're given are going to go into the brain. Kisqali
Right,
doesn't,
right.
fulvestrant does, abemaciclib does a little bit. But the objective response is صغير anyways, like 20 something. So I think, what is that?
Yeah.
Limited efficacy.
Oral approved الالستران كابيفازرتينib,
Uh-huh.
Alpelisib, even antibody drug conjugate, apart from trastuzumab deruxtecan, have low or minimal brain
But
activity.
right. That is correct. You're absolutely right. Trodelvy actually have a little bit better than this. They have data for LMD كمان. With
Mm.
detolimab, deruxtecan also have
But we
some.
have
Mhm.
we have brain mets too. Do you think that the blood-brain barrier is functioning well?
Yeah, well,
Controversial.
in the ER positive, probably the answer is still a yes. And despite this, you measure intracranial activity, because actually that was done already. They measure intracranial activity. I'm not sure which that was the University of North Carolina study that did get a lot of the data on the Abemaciclib. They had a brain mets center, so the intracranial concentration tends to be much higher with the Abemaciclib compared to the other CDK4/6. But again, you're right. With a patient like this, I'm not sure في ADC بالذات if we're not going to see them intracranially. They might have a little bit of a better activity than in patients with no brain mets.
For this cases, do you routinely screen for leptomeningeal metastasis through MRI, whole spine, CSF analysis, or you just stuck with the CT brain, MRI brain, enough for you?
We would do an MRI, but I don't think, if you don't have symptoms concerning for LMD, because LMD is mostly clinical, right? So if you don't have symptoms concerning for LMD, I wouldn't go to do like a lumbar puncture and look for cytology, because even if cytology was negative, doesn't rule out LMD. Like if I'm a patient who comes in, brain itself, no parenchymal disease, but she's like wheelchair bound, right? Or significant headaches or photophobia. And you have meningeal enhancement on the MRI. Even if you do like 3 or 4 LPs and are negative, I don't care. Does that make sense?
So is there any role for intrathecal treatment? Like giving intrathecal methotrexate or
For this
anything?
patient?
Without positive CSF, I don't think so. Because you follow up بالintrathecal with CSF full clearance. That's
What are you treating? What are you treating? If you're treating
leptomeningeal.
intraparenchymal disease, The answer is likely no for intrathecal. There is a small paper that was a small poster for ASCO 2025 that actually included BEV, حطوا bevacizumab مع God, it's one of the novel PD-L1 agonists, PD-L1 antagonists, sorry, with BEV and carbo, and it had like a very good intracranial activity. But that's just something. And a patient like this, again, to answer your specific question, and احنا ممكن نتكلم a lot about all of these different. I don't think there is data to support intrathecal. Intrathecal is typically reserved only for leptomeningeal disease, and even in these cases, the true benefit remains very questionable. The data series with MD Anderson هنا was topotecan, an ER positive intrathecal topotecan, and they really hadn't had a whole lot of luck. Again, remember, this is very rare. Now you see more in TNBC for sure, and in HER2 positive طبعا. And then in these patients, you can do intrathecal topotecan and Herceptin, usually alternating. You do the combo and then you do intrathecal topotecan. Even that did not demonstrate significant survival benefit, but it did improve quality of life.
Right. Regarding the brain metastasis, would it be a better idea to do resection first than adjuvant SRS, or SRS from the start is sufficient?
Yeah. I don't have any data to see which one is necessarily better. I can tell you that in practice, we're doing more and more SRS, and that the outcomes are, doing better and better. They used to have 20 as a cutoff for SRSs. They don't do that anymore. They just SRS whatever they're able to find. However, لو هم very well defined 2-3 masses, very well defined. I've seen, surgeons occasionally taking the largest piece out, especially if we want tissue. But I think that this does not change overall outcome. I really don't think so, at least as far as I know. Maybe Dr. Manar can shed some light على النقطة دي. Well, I don't think it will change their outcome.
طب what about biopsy of البرين metastasis to assess the HER2 status, HER2 low, HER2 ultra low? We have now Disney breast 12 demonstrating efficacy of trastuzumab deruxtecan, and Disney breast 6 demonstrating efficacy in ultra low HER2. What do you think about that? Does this justify a need for brain biopsy?
قلت لي lumbar puncture كانت high opening pressure.
Negative.
But no increase in
Cytology.
pressure.
No comment. It was treated at another center initially, so no data.
I don't think I would open her brain just to kind of check her two status. Honestly, with the GBO6, as you mentioned, I would just ask the pathologist, بص كده على البلوك تاني كده قول لي, are you really seeing أي HER2? Most of the time, هتلاقي some HER2 lying around, 5, 10, the 0+, which is the ultra low. So, if you really want to do an ADC, which is a very reasonable option to her at this junction, I think I would do that. And I would actually focus on HER2. I would not do Trodelvy or Daro because, as you mentioned, they are usually approved post-chemotherapy. So her junction would be either, chemo or targeted pills like what you have, or HER2. But I wouldn't do any ADC other than those.
But I think since she has other mutation like PIK3CA and ESR mutant, I think I would postpone giving ADC for later lines. Or what do you think?
Yeah, I agree. I agree for sure. I think that if we have a good disease control for the brain and her systemic disease just bone, She has both ESR1 big 3CA, but she has a truncal big 3CA. And I would probably do fulvestrant capivasertib. I think that would be the best approach to her. Many people are not comfortable with elacestrant single agent in this setting. Or a single agent, we don't even think it works that well, to be honest with you. But they're doing the follow-up combination with CDK4/6. But for a patient like that, I would just go for capivasertib and fulvestrant, hope for the best, see how she does. But have a plan for very likely in HER2 post progression on that combination.
طيب. Regarding the bone metastasis, in your practice, how to follow up them? Do bone scan, PET-CT, just
I do
clinically,
PET scan.
PET scan.
Bone scan in my experience is very challenging to interpret ده من ناحية, and then it is grown. Like if you look at the sensitivity, you're talking about somewhere between 92 versus almost 80% on the bone scan, on PET-CT versus bone scan. And so I've been using less and less bone scans, and you only need one patient, which I had one patient in which CT, chest, and pelvis bone scan were all clean, but I did PET-CT because she had a focal pain in one of the appendicular. It was like her left humerus. You just one patient, and she had the biggest osteoblastic lesion that you can see, completely missed on the bone scan. I talked with my radiologist, on the bone scan, and they're like, "Oh yeah, no, well, I mean, 1 in 5 will not show on the bone scan." And I was like, "أنت جاي تقول لي دلوقتي." So this is the thing, it is 80%. So it's 1 in 5 will have a negative bone scan despite having a disease. فبيت سي تي that number goes almost to 1 in 20. فعلشان كده I think that it's in my experience PET CTs outperform, and I usually use كمان دلوقتي we have Seriana, so I actually use Seriana when the patient insurance يعني يديني الoption, and Seriana would actually help. So are you familiar with Seriana? So Seriana, instead of using FDG, instead of using sugar, D-glucose, it uses FES, fluorinated estradiol. And then in a patient like
Approved,
that,
right? Approved, FDA approved.
FDA approved, yes.
Yes.
2000
Not available in many regions.
not available for America, for many places, but it's now available for Houston. Houston used to get it from Dallas, but it's now available in Houston. It is now it's incredibly powerful in a case like this, because Seriana doesn't just give you location, it gives you activity, right? And it gives you biology. So FDG will give you location and activity, but Seriana also give you biology. So if it lights up, an answer to Dr. Henry's question, if it lights up, I know it's ER positive for sure. I know it has not lost its endocrine situation. And the caveat with the Seriana, though, is that you cannot use it مع fulvestrant, because it down-regulates. Fulvestrant makes it ER negative, essentially. So you have to stop fulvestrant if you really want to try Seriana. However, with that limitation in mind, it's a great option for following up patients prospectively like this. But a bit CT would do very well as well.
As follow up for our case, after SRS, MRI brain free, necrotic just necrosis, and the PET scan negative for metastasis. And the patient already started on capivasertib fulvestrant for around 1 year. What to do now? Do you continue? Because we face this clinical challenge frequently in our practice. Do you continue till progression, or you stop treat, or what is your approach for such dilemma?
If she's able to tolerate capivasertib well, and hyperglycemia is not a problem, rash is reasonable, and fulvestrant is doing okay, I will not touch this patient. I will continue to treat
Till progression.
Yeah,
till the progression. I will not touch
I
it.
would do that too.
Dr. Menard, this is the kind of patient you pause for like a week and then the disease just shoots up.
Yeah, and it would be my fault. the patient would think it's my fault because I
Yeah.
stopped this treatment.
Yeah, exactly. Which is really isn't, you know. But then the other thing that is becoming more and more used, and well, it's more of a case by case basis, but it's MRD testing. So MRD testing, يعني مثلا I use it في Baylor, I use it very frequently. أصحابي هناك في MD Anderson do not use it. Like, they don't want to use it. So it really depends على you know, the data we have actually support its use, but the regulatory bodies have not yet approved it. But MRD testing using حاجة زي Signatera or Personalis would look at her original biopsy, and then they will quantify to me, you know, how many cancer cells are out there. It is tumor marker. I usually don't use classic tumor markers, you know, BR and CA. They don't correlate that well. In some patients, they correlate okay. يعني لو أنا مثلا in this patient, her tumor markers correlate with her being controlled and then progression, then I might use those. But generally speaking, they don't, especially in the طبعا, you know, we don't use it in the adjuvant setting. But MRD testing is much different, and I would يعني add this as an additional layer, you know, to demonstrate that disease is responding or not responding. But this is something that يعني again case by case basis, and it's not yet in the NCCN or ASCO guidelines.
Do you have access to Inavolisib or not yet? Inavolisib?
Inavolisib? Yeah. Yeah, so Inavolisib was approved last year, and it's you know, it's a good drug. It's toxic. The regimen is toxic. So Inavolisib, fulvestrant, Balbo. You know, we have not been using a lot of Balbo since the survival data with Balbo were negative. So we've been using more Ribo and Abema. But when the Inavolisib approval came in, we've been using a lot more Balbo. That regimen is a little heavy. It's involved 3 drugs, a lot of myelosuppression, a lot of stomatitis, you know, hyperglycemia is high with Inavolisib. Okay, so it's not like capivasertib. It has a high, you know, but that regimen works really well for patients with aggressive disease. One of my LMD patients is endocrine refractory, and I started her on that regimen. She actually, interestingly, does have LMD disease, no intracranial mets, but definitely LMD. And that medicine completely, she had bulbar symptoms actually, and that medicine completely reserved, Inavolisib completely reversed her symptoms. And we do Tempest, so I do Tempest as an NGS. Garden 360 is, yeah, it's pretty much like Garden 360. And you can see the VAF in her big 3CA, variant allele frequency, keeps going lower and lower. So we're actually knocking down a lot of these driver mutations.
Have you ever tested the sequential CDK4/6 approach switch from Ribociclib to Abemaciclib?
Yeah, I was part of the post-Monarch. So this is something that, you know, Dr. Kalinski, actually Kalinski في Emory هو اللي presented these both data, post-Monarch and the maintain. And I didn't, maintain was good, but it wasn't, you know, single arm, and there had some biases in it. But the post-Monarch was very reasonably designed and randomized, and it's a good trial. And yes, my practice, let me share with you what I typically show الfellows. بس يعني التيم بتاعي we developed this algorithmic outline. Here, I'm gonna share with you right now. It's on my GitHub, but I made a GitHub page. هتجي في الchat. So this is like an algorithmic outline I used to teach الfellows يعني, and I actually used it to also discuss it with some of the talks. And I usually tell them, if you have a soft progression, so let's say your exact same scenario.
Dr. Rafi, can you share? Can you open what Dr. Kanani open?
Stop. Pause or stop?
You can open it on your screen. It is on the chat.
In chat.
The link.
Yeah, it's in chat. I think is it made it? I think so.
Appeared yet? Okay. I'm not sure.
Still chat right up there.
You can unshare also.
Not sure. Stop share.
Okay.
Do you want me to
Let's
share?
start.
Okay, let me share.
Can share it, Dr. Hanani, if you want.
Of course, here you go.
Can.
Can you see?
Yes. Yes.
Okay, so let's say this website is on my GitHub, and I use it to kind of teach some of the fellows, but also in some talks. Let's say, مثلا this patient. So we'll go. She's postmenopausal, right?
Yes. Yes, she's
Stage
postmenopausal.
4, and so I go stage 4, and then I go to first line. So her first line was here, right? So she had AI and a CDK4/6. And I put in
Yes.
Riboard with Palomatoon as a 2 monarch 3. And then I see here for non-de novo PIK3CA mutant can consider inapple. So that would be a first line. And on second line, I tell them if there is soft progression. Now there is no distinct soft progression sort of definition, but these are the patients who essentially develop, with bone only or bone dominant and just have like a bone only disease or a small progression on like an additional lesion. If she was an AI alone versus the majority would be on AI and a CDK4/6. And then, right, so this is what I try to always tell, that instead of just jump into the next big gun, take it slow and just one step at a time, because it's not a sprint, it's a marathon. Because this is really what it is, right? Is to maximize the amount of time where patients are on your lines of therapy.
Also, it would be
Mhm.
a good option if the patient not candidate for BIK3CA due to poorly controlled diabetes.
Diabetes مثلا, of course, right. You can also use طبعا Afinitor. That remains an option, with fulvestrant. I think I have it here somewhere, maybe. No, شلته خلاص. But an older option would have been to use مثلا if he doesn't have any targetable mutations or you can't use them, if Bolero with exemestane and Afinitor. But I think I forgot its name, but there was also data for fulvestrant and Afinitor. And that would be also another option. But that's in case that you don't want to do a CDK. And I think that this is a very reasonable next step. All right, I actually have it here. Soft progression in AI alone, Afinitor with AI, tamoxifen or fulvestrant, Bolero and Tamared and BRE. I think I put it here, and you didn't have data on Afinitor purely after CDK4/6. عشان كده I'm gets hesitant of. But anyway, so this would be like a soft progression, as you mentioned, PIK3CA. I would definitely go for Capitello data, given that this is much more elacestrant as a single agent gets a little bit tricky. She's young, so 52, so you might sometimes want to check her somatic and germline mutations for HRD.
She was tested, was negative in
Negative. Yeah.
In your practice, if a patient, like our patient, have a both mutation, BIK3CA and the ASR1, which one to prioritize?
I'll stop sharing. Which one? I would typically go for PIK3CA لأنها downstream, right? So when you have both mutations, you block, because even if you block ESR1 itself activation, the downstream of ESR1 is the ACT pathway, which is hyperactive. So I usually go to PIK3CA because it just makes more sense لأنها downstream from ESR1 hyperactivation. And again, as I said, I'm not really sure how much elacestrant single agent is doing to hold off the ESR1. We
I
are
think
having a lot
combination.
more. I'm sorry?
Combination now is an option.
Yeah. Not yet. We have a lot of حتى يعني the other oral SERDs اللي go on the market as well. So you have capivasertib. No, not capivasertib, I'm sorry, camizestrant. You have camizestrant. and you have imlunestrant,
Mm.
and vibdigestrant, and all of these are single agents. Imlunestrant did add in their trial اللي هي Ember 3 trial with
Mm.
imlunestrant versus standard of care, but they added a third line, imlunestrant with abemaciclib.
Mm.
And this line actually looks really promising, looks
Mm.
really active, but it's, we don't know if this is gonna ban out. فعشان كده so far كل الاورال SERDs, the only one approved هو الالسترين, which is single agent, and the entire rest كلهم single agent activity, and كلهم are compared to fulvestrant as well, except with that tiny exception بتاع imlunestrant.
What if the HER2 in repeat testing was low, +1, and now we have VIK3CA, SR1, and the HER2 low? Should we
Pick
prioritize?
rate, I would probably still go for the big 3CA, and save in HER2 for on progression, because you have a good control on the brain. Again, the thing is, it's becoming complicated in a good way, as I mentioned at the very beginning. But that tells you that there are multiple paths to the same conclusion. So escalate as the way I'm thinking about it, and the way I'm actually was literally this morning could have given a talk for the Benitera Foundation, and then I was talking about the advances in the metastatic ER positive. And then one of the physicians for community was like, "Taib, we have so many options now, this is getting very confusing." And I was like, well, don't confuse yourself. First off, work by the guidelines. You have guidelines, you just work in the guidelines. But two, know the limitations of each of these options so that you escalate as needed. So it's kind of like you have options. You go in, you want, I don't know, you want a Volkswagen. انت داخل عايز تجيب جيتا, Yes, you might have money to get BMW, you might have money to get Mercedes, but you don't need all of these, right? You want this. So focus on what's just going to control the disease, I'll give you another example. In ASCO كان في طبعا انت اتكلمت على 3 and then there was DB09, which put it البتاع in the first line, but
First line.
in HER2 for first line. Or actually Ascento 4, which put sacituzumab govitecan in the first line in triple negative breast cancer. So a very reasonable question is, هل treating patients with these very active drugs at the first line, and then honestly kind of scrambling or doing whatever about if it's second line, is that a better strategy than the other way around? Like we're bringing all of these very active drugs in the first line, which is fantastic. But what's going to happen next? We had something to fall back onto. And you might say, well, that's the natural progression. Jamil, but then give me something in the second line. We don't have anything yet, right? If I give you an HER2 in the first line and HER2 positive, and then you progress, okay, yani, there are some options, but with it better, wala, just wait it out, and then give an HER2 at the second line. And this is the same scenario as bringing these stronger agents sooner and sooner. We are left with the decision of, what are we trying to achieve? We are trying to make the disease sort of like controlled for as long as possible, right? And this is bringing these very strong agents in the beginning is very similar to you throwing linezolid على حد عنده like an abscess, right? It does sometimes feel that way. And again, exactly because of this, the biggest concern on Destiny Breast 09, despite the fantastic responses, is that do we really need in HER2 for 4 years? Because they have been like almost 4 years. For 4 years for these patients, way too much toxicity, way too much activity for a first line who typically do very, very well. So that's just an example of where the conversation is going.
We have this dilemma, especially when working in a limited resource setting. Limited options, and if we give everything in the first line, then we ask ourselves, what are we going to do next? Probably give him some chemotherapeutic agents, and all the patient gets is the toxicity and no response.
Yeah, and you're absolutely right. Burning lines very quickly, and للأسف I've seen that, especially in the ER positive, people will like switch treatments after 3 months of of pills. Not working. اللي بعده not working. So I see these second opinions, like 6, 7, 8 lines of therapy over the course of 2 years. I'm like, that's not normal, you know.
Mm.
And and the patient طبعا is right, no. So you're running through your lines, you're not using the lines in a strategic way, and
And
this, yeah,
and we have data actually supporting sequential Sonia trial. We can start just AI and
yeah,
a second
yeah.
line, we can
Y-
save CDK4/6 inhibitor upon progression, especially
You're up.
indolent disease, elderly patient,
Yeah.
mineral as here.
And a fantastic example, This is exactly يعني I can put it much beautiful, and you're absolutely right. And حتى لو انت actually شفت algorithm that I just shared, you will see that one of the treatment in the first line setting that I put there is AI for small volume of disease, just single agent AI. It's very reasonable, because the patient at the end of the day, especially with these bone-only, bone-dominant diseases, tend to actually do very well for the majority of time. My mentor, who I worked with for a very long time, Dr. Matt Getz Mayo. So we had that huge discussion before. He طبعا يعني an avid proponent of the CDK4/6, but I had a discussion with him like, well, he said to use them causes overall survival benefits. So why would I just not get them from the beginning? But I guess the answer really is, it's the overall survival happens by the introduction of these agents. That's why we still see benefit in the second line setting. So if that's the case, and I have a 70-year-old, why would I try to get them in the first line? I don't see any incentive. I have overall survival in second line. Have it on an AI for a couple of years and then switch.
Right. Great discussion with you, Dr. Ahmed, actually.
Nah, great discussion with everybody صراحة يعني. This is a very well thought of, very well researched job يعني. I cannot يعني thank you enough for such a mental stimulation.
Rapid refresh.
Thank you so much, Dr. Hanani. Hopefully we can meet next month.
Yes, absolutely. I would love to. We should tell people how great of a discussion that was, and try to bring more people just to kind of enrich in the viewpoints. I feel أنا عمال
Okay.
أسمع صوتي too
Because
much.
it's
So
shared also on Facebook, multiple places. So
yes, yes. يعني you shared it على الجروب and على X. So yeah, thank you, Mustafa.
thank you,
Okay, I
everyone.
think
Yeah, go ahead,
okay,
Dr.
we will have also journal club next month, right, Mustafa?
Yeah, we were trying to do like a journal club. Dr. Khanani, are you available next week?
Next week, I think so. Let me double check it quick.
We were trying to make it after the after the tumor board, but Dr. Higazi was mentioning that it's better to be separated. So
A little bit, yeah. And tumor boards, it's hard to. I'm available next week, inshallah. Yeah, tumor boards hard to determine when they will finish.
yeah, so yeah, we'll do it next week. We have one presentation about a clinical trial, also breast. So
Fantastic.
okay. Anyone has questions?
Thank you, Dr. Mustafa. Thank you, Dr. Manar. Thank you, Dr. Ahmed.
Thank you, Dr. Alfie.
Yes, for sure. Thank you so much, Dr. Alfie. يعني صراحة incredible work. And Dr. Manar is you're the mentor, Dr. Manar?
She's
Exactly, but we had similar difficult work conditions.
Wow. It's interesting. I think we do you know that Dr. Khalid, who actually was يعني دخل for a short amount of time, You know, we've set up an ASCO Egypt, he set up ASCO Egypt collaboration. Are you familiar with that?
Yeah, I heard the news. Yeah, it
So
would be
I
great.
think that this, right, I think that this is, and I want to share it في البتاع في الشات برضو. I think this is a great starting point, and by this setup you are technically eligible to apply على أي ASCO grant. You know, well, you have to be an ASCO member or sponsored by a member, but you can apply to ASCO grants. And there is actually one grant that I think might be very good. Let me show you which this is how we can start becoming more academic, you know, and they will support these type of stuff. لأن هم when they support grants and يعني في outside the states, they basically get presence there and they want to counteract ESMO to a degree. But ESMO doesn't really give a whole lot of grants. برضه الفلوس عندهم على قدها. But ASCO gives good amounts of grants. فلو دخلت
Grant for research or grant for attending the meeting?
there are all types. There are this and this. يعني I will في grants already معمولة for international development grants here. I'm gonna get you the that's the main one. Okay. وكل الايديا grants وكل الانترناشونال grants they also sponsor attending الميتنج بس بيكون فيها more than this.
I think it is very competitive. I applied many times.
يعني never harms. I mean all the grants are like this بس يعني it's not as competitive as you think it is صراحة. There are 3 grants للinternational. اللي أنا بعتها دي is the more common one. But there's also international innovation, which usually requires institutions, which is essentially just American, and then the global investigator ديت. Definitely worth in على الأقل يعني we think
Right.
about this, and maybe after tumor boards مثلا next time we can not tumor boards or اسمها ايه journal club.
Journal.
We can even dedicate some time to look over those and come up with, you know, if there's a grant we can apply on أو حاجة زي كده. You know, somebody can start working on حاجات دي. You know, I think it's very reasonable.
Yeah, especially for young fellows.
Okay. Wonderful.
See you next meeting. Bye.
Next week.
Thank you, everyone.
Thank you.
Thank you.
Lovely night.